Hi, welcome to the office. I'm Dr. Vinton, and the purpose of today's visit is to find out what is the underlying cause for the problem that you're having in your joint. Now, the first thing I guess we should say is that we're going to spend about an hour today, so just relax. We're going to spend some time doing some paperwork. We'll spend some time reviewing your history, performing an evaluation, taking some x-rays, as well as going over those together so that we know exactly what we're dealing with. So I guess the first thing we should talk about is what is normal. So normal for a joint, and there's actually something called the Kellgren-Lawrence scale, which we'll go over, but the Kellgren-Lawrence scale defines a joint from absolutely healthy to a little bit damaged, to more damage with arthritis, to totally bone on bone. And it would really depend upon which of those phases your joint is in, as opposed to what the most appropriate treatment would be. We typically, on this end of the scale, when a joint is very healthy, standard things like therapies and whatnot of varying kinds typically do the job. Most of our patients have some form of varying degeneration in their joints, and that's why they're here, because the therapy hasn't worked. Most folks then moved on to the cortisones. So the problem is cortisone itself causes more arthritis. And as most people have found out after multiple rounds of cortisone, they still have their problem, or it's actually gotten worse in pain, and they're not able to move as well as they could before. Because even if cortisone does its job in relieving some discomfort, what it doesn't do is protect the damage in the joint. So as a result, every step you take causes more pounding in the joint. And as the cortisone wears off, you actually now physically have more damage to the joint. In addition, one of the known side effects for cortisone is it actually pits or damages the gentle cartilage in your knee, causing it to degenerate further. It causes the ligaments to thin and shred, causing them to become weaker, causing more arthritis. And most folks are completely unaware that every injection of cortisone causes a bit of bone loss, which eventually will lead to osteoporosis. And if a person has enough cortisone, it'll actually cause the bone to melt like handle wax, and what's called avascular necrosis, it'll actually cause the bone to die. So although cortisone has its place, it is very short-term and very limited, and it by no means fixes the underlying problem. The next step that most people take is the rooster shot or the gel shot or the chicken shot. And what happens there is that is actually a synthetic lubricant, kind of like a lube job for your car, that physically lubricates the synovial fluid to try to help protect those joints as they pound together. What it doesn't do is stop the arthritis. So you have that done every 6 months to a year. And what will happen is that each time you have it, it typically works less long. So maybe if the first time you had it, it lasted 6 months like it's supposed to. And maybe the next time it only lasts 4 months. And maybe by the third time it only lasts 2 months. And the reason is because although you're getting some temporary relief, the problem is it doesn't fix the underlying reason why. As a result, you end up with more arthritis as time goes along. The next step after the visco supplement would be something called PRP. It was actually made kind of a household word by Hines Ward and Troy Polamalu during the 2011 Super Bowl. Neither one could play. And a week later, they both played in the Super Bowl. And people said, how did you heal so quickly? And the answer was PRP. What PRP stands for is platelet-rich plasma. Literally, it's a blood draw out of your arm, and they spin the blood in the centrifuge. And the top layer of the blood separates into what's called the platelet-rich portion. And it's platelets that heal. So if you cut your hand, what allows your hand to heal are platelets. When they do open heart surgery, they'll squirt some PRP in to help those ribs heal quicker. What happens is the platelet-rich portion speeds up healing, it causes new blood cell formation, and it also causes degeneration to stop. Now what it doesn't do is it doesn't grow new tissue, but what it does do is help the tissue that's there to heal. So the PRP has a big proponent in helping joints and arthritis from progressing further. What happens if a person is beyond what PRP can do is now we move into stem cell therapy. Stem cell therapy has been around for many, many years, decades. Our clinic has been working with it for over 25 years. And what happens is stem cells are what we're made of. Stem cells are primordial cells. Stem cells, actually, we couldn't live an hour without our own stem cells. And when we're an infant, one of every 10,000 cells that we have is a stem cell. By the time we're 16, that's about 1 in 40,000. By the time we're 50, that's 1 in 400,000. By the time we're 60, that's 1 in a million. By the time we're 80, that's 1 in 2 million. And what happens is if you watch a 2-year-old fall down, they jump up a lot quicker than if an 80-year-old falls down. And the reason for that is the plasticity of the tissues, which is directly related to their stem cells. So what happens is when we do stem cell therapy, this is no longer a treatment. This is actually a cure. Stem cell therapy only does one thing. It grows new tissue. Not sometimes, all the time. That's what stem cells do. Whatever they come in contact with, they begin to replicate and make new again. There are 4 legal places to obtain a stem cell. 2 come from your body and 2 come from a donor. The ones that come from your body actually come from your bone marrow in your hip or from your belly fat, like with a liposuction. The problem, however, is if you're over the age of 30, those stem cells are too. And as I often tease, if you're old and decrepit, so are they. If you have diabetes, so do they. If you're on multiple medications for multiple other health conditions, so are they. So they're not the best place to get a stem cell from if we're looking to regenerate a joint. The second reason that they're not the preferred place to obtain stem cells from is because they're what's called hemopoietic. Heme simply means blood. They may be good for an IV, for like a whole body rejuvenation, but they lack what's called cytokines and growth factors, which are very necessary to help a joint to regenerate. And what a cytokine or a growth factor is this. Let's assume you bump your elbow and it swells. There's actually an inflammatory process, and part of that inflammatory process, the body sets a chemical messenger, like a road flare, into the system, and what happens is your natural occurring stem cells are drawn to that area to help it to heal. As it heals, there become less cytokines and growth factors, and as a result, the body knows it is done healing and the stem cells move on to the next part that needs attended to. So what happens is the fact that these stem cells that come from your belly fat or from your hip bone are hemopoietic and they lack cytokines and growth factors, they don't have what's necessary to help a joint like grow new cartilage or grow new meniscus or grow new fluid. And so therefore, athletes 30 years ago used to go to Germany and have these things done because Germany doesn't have an FDA. And as a result, they can mix in cytokines and growth factors and other things to those stem cells at a cost of $50,000 an injection to help those things do what they needed to do. The fantastic news is technology now allows us to obtain stem cells that come naturally with cytokines and growth factors, but they come from a donor. And that because they come from a donor, they're technically called a tissue allograft because it comes from another person. In this case, they actually come from umbilical cord blood. When my assistant had her baby just recently, she was encouraged to save the umbilical cord blood. The same with my daughter a few years ago, was encouraged by the hospital to save the umbilical cord blood. So should the baby ever have a problem, they can simply go to the cord bank and retrieve their own stem cells and help heal their own organs. So what happens is for mothers who choose not to do that, they become donors. And they literally go through a process all through their pregnancy of being screened, just like you would for any other organ. And at the moment of delivery, once the cord is clamped and mom is handed the baby, the rest of all that, which is typically discarded, is processed and frozen to negative 200 degrees Celsius within an hour. At negative 200 degrees Celsius, it'll last forever. And when it's thawed out, those cells are very viable. So if you're 50 or 60 or 70 or 80 years old, when we inject a stem cell into the joint, it's just hours old. Think of it like having a 2-year-old run around inside your knee as opposed to a 70-year-old run around inside your knee. So not only are they viable, and not only are they more potent and more in number, more in volume, but they also come from nature with those cytokines and growth factors. So when they're injected into the joint, they have the ability to separate into 6 different kinds of tissues, whether we need cartilage or bone growth or to resorb the arthritis or to grow new meniscus or new fluid. And as a result, that's typically what we do to help people to avoid from having a joint replacement surgery. Let's talk about a joint replacement surgery. Folks are often unaware that even after, let's say, a knee replacement, half the people still have pain. Of an average on a scale of 0 to 10, of an average of about a 3, and as high as a 5 depending on what activities they're performing. So even after the surgery, their pain ranges from a 3 to a 5 out of 10 on a daily basis. So the pain doesn't go away. The second part is all the trauma that happens from having the knee replacement. 6 to 10% of people get the infection. Now the infection can last weeks or even months. I've seen it last years. And as a result, during that time, you're unable to do your normal daily activities. The second thing is that with the joint replacement, you're going to have 3 to 6 months of physical therapy. Your knee is going to be constantly, let's assume it's a knee or an elbow or a shoulder, will constantly have a bit of numbness to it, and it may or may not regain its full range of motion. And it always feels just a little bit different because it is. It's a titanium or a metal implant. So the reason that stem cells have become so popular, in the year 2000, 90% of people had the joint replacement. Only 10% had the injection. By the year 2015, that was 70-30. 70% had the knee replacement or the joint replacement. 30% had the injection. The prediction is by the year 2022, that'll be 90-10 the other way. And the reason is because people get to keep their own joints. They don't have the long recovery time. They don't have the risk of all the infection. And once it's injected, other than maybe taking it easy just for 72 hours, there really is no downtime. 65% of people historically have the pain relief that they originally sought by the 30th day. As that tissue continues to regenerate, as month 3, 4, 5, and 6 go along, 95% of people are able to do the tasks that they want to do without pain or limitation. That stem cell will continue to heal for up to a year. So when we do a reevaluation at the 6-month point, we typically see the joint space opening up. We typically see the arthritis resorbing. We typically see roughly 20 to 30 years worth of damage being peeled off of that knee. And folks are happy because they can go on and enjoy their life. And the key thing is they can keep their independence. They don't have to burden their family with helping them get around, whether it's from having a joint replacement or heaven forbid they had an infection from the joint replacement. And the key thing with joint replacement is folks don't understand, and doctors often don't tell them, and it's the third most common reason people come to see us, is 1 in 200 people die of a blood clot after a joint replacement within 30 days. So the idea of being able to regenerate that joint and be able to keep the parts that God gave you, to be able to keep your mobility and independence and not become a burden to your family, is a huge reason that that pendulum is swinging to, like we said, that soon it'll be 90% of people just have the injection and only 10% for whatever reason will have the joint replacement. Now, all of this is based upon that Kellgren-Lawrence scale that we spoke of just a moment ago. If we have little to no damage, then yes, therapies and things tend to work just fine. If we have a grade 2 or a very early grade 3 damage, then the visco supplements lubricate and do just fine. PRP also works well in that category. Now, stem cell can be done anywhere along this path, but especially as we move into the mid to late grade 3s, where there's significant arthritis in the knee. As long as there's any space left, the stem cell will work. If it is totally bone on bone, and I need to say something about that just because I talk to hundreds of people every week, and every one of them, their doctor tells them that they're bone on bone. In reality, when we actually do the exam and take the x-ray, less than 4 to 5% are actually bone on bone. Most are a mid to late grade 3. There's significant damage, but there's still plenty left to regenerate with the stem cell. So what I'd like to discuss now is what normal and abnormal look like, because in a few minutes we're going to meet and begin your evaluation and take your x-ray. And what it really comes down to is real estate. It comes down to how much damage is done to the joint and what's left to work with. What I'd like to show you is 2 things. The first thing is when we take a look at what a healthy joint is. In this case, it's a knee, but a shoulder or an elbow, they're all pretty much the same. The bone above and the bone below have cartilage on them. We think of cartilage like Teflon on a skillet. Think if your Teflon is nice and smooth, your eggs slide right out. And if we have the meniscus, which are the spacers, we have ligaments that wrap all around and hold it into place. And what happens is around the whole thing is a giant water balloon. And in that water balloon, it's actually a joint capsule or a bursa sac, we call it the water balloon, is the synovial fluid. That's what lubricates it. Now, synovial fluid is thick, like an egg yolk. And what happens, though, is when you get arthritis, is it thins out, more like water. So what used to cushion every time we take a step or every time we move a joint, no longer cushions and the bones begin to pound. And what that begins to do is that begins to cause damage to the cartilage. Much like if you scratch your skillet with a fork, your eggs don't slide out as easy. The same thing happens to the joints. They begin to creak and crack and maybe not move as well as they used to. That then causes more pounding, and that pounding begins to damage the meniscus. And to self-protect, the body starts to lay down more bone, kind of like a spot weld to try to protect itself. That's the arthritis. And as the bones get closer together, these ligaments, which are usually tight, they begin to sag. And what that allows is every time you take a step or every time you move, the bones rub even more. And that's how the arthritis promulgates. So what needs to happen is we need to inject something into the joint to stop that process. As we said, the visco supplement, if it's an early grade of degeneration, can help lubricate it and stop it from pounding. But once we have severe arthritis, that will no longer work. That's where stem cell therapy comes into play, because it will literally help to regenerate the cartilage. It'll literally help the body to resorb the arthritis. It'll literally help those joint spaces to open up. What I'd like to show you is an x-ray of a patient who chose not to take our advice and continue to have cortisone injections, even though we explained, as bad as that is. If we take a look, we'll see that there's very, very narrow joint spaces. We'll see a lot of bone spurs. And with that, even though that's a strong grade 3, she's a prime candidate for what we do. But by having cortisone and allowing those bones to keep pounding, and this is something that many people don't quite get, is the idea that when we have a lot of space, there's cushion. But the more degeneration there is, the less cushion there is, and the more pounding there is, and the more that happens, the faster the arthritis accelerates. And in her case, she said, "I'll call you when the cortisone no longer works." She called us about 8.5 months later, and we took another x-ray. And in that particular case, her bones had already fused. There's nothing more could be done. She was now forced to have a double knee replacement, which she did not want to have. And she didn't understand that her knees could degenerate that quickly to where they completely fused together. Now, conversely, this next image is of an 88-year-old man. He had a surgery on his right knee, said it was so horrible he's never going through that again. And you can clearly see the outside of his knee has plenty of space. The inside of his knee is not quite, but almost bone on bone, because he did not want to have surgery. And that's a very tough case. That's like a grade 3.9 out of 4. It's not fused, but it's pretty close to being fused. We went ahead and did his injections, and we took an x-ray 4 months later. And as you can see, although not perfect, it is substantially better than it was. There's probably 5 or 6 times more space in his knee because that tissue regenerated. So what happens is we have the ability, science and technology now give us the chance to begin to reverse that damage pretty much anywhere in your body, so that we can delay or prevent from ever having had the surgery and the complications that go with it. In addition to choosing the finest quality of tissue allografts or stem cells, the next most important thing is making sure that the injection actually gets inside the joint. It sounds crazy, but 85% of physicians do what's called a blind injection. They literally just kind of feel and then stick the needle. The problem is, in a knee joint, they miss the joint 25% of the time. And the tighter that joint is with arthritis, the more chance they have of missing. Shoulder joints, on average, are missed 55% of the time, just because it's a blind injection. Now, 10% of physicians will use an ultrasound and literally guide the needle as they go. 5%, like a surgeon, would use a fluoroscope. Now, a fluoroscope is a motion x-ray. It allows us to see directly inside the joint. So first we use just a little bit of dye, and as we inject the dye, when you hit the joint, you'll see it fill in on the computer screen. Once you know that you're in, you can unscrew the dye and screw in the injectant. And when you inject, you actually watch it fill in so you know that you have 100% placement. And that, in addition to the highest quality of tissue allografts or stem cells, plus the proper follow-up, allows us to have the highest potential chance for success to restore the damage in your joints and allow you to return back to the things you enjoy doing most. Now, I do need to tell you that for most people, they like to talk about what their insurance will and won't cover. I will tell you, for a starter, there is no charge for today's visit. We never have in over 30 years. So just relax. Let us get through what we have to do with the exam and the x-ray so we can have the information we need to have an intelligent conversation. Now, once we take a look at the amount of damage, If it's a grade 1 or a grade 2 or even a very early grade 3, the visco supplements will work just fine, as well as will some therapy, maybe a decompressive knee brace, and your insurance covers most if not all of that. But if, as many of our patients have, it's a mid-grade 3 already pushing in towards a grade 4, I have to tell you that insurance does not cover PRP and does not cover stem cells. In fact, surgeons are fighting like crazy legislatively right now to have that not happen because they get $60,000 for every joint they replace. The average surgeon does roughly 5 a day. So that's a lot of income and that's a lot of lobbying power that's working towards having stem cells not be covered by insurance. So even if what is required to correct your problem is beyond what your insurance would normally cover, breathe easy. We offer multiple payment plans from different companies that have payments as little as $20 a week. And we find that most people can fit that within their budget, regain their health and mobility, and continue to enjoy the quality of life that they've always enjoyed without having the limitation of pain, and they can get back to the things that they love doing most. What I will also say, and this is part of what allows us to have the success we have, is we're going to do a full body examination. So in just a few minutes when we examine, we're going to examine from the top of your head all the way to the bottom of your feet. It's all connected. So we know for a fact that if we have a dropped arch, that it can cause a torquing in the knee. We know for a fact that 30% of our patients will have stenosis. They don't have any back pain, but there's closing off, just like you don't feel an artery clog until you have a stroke. Their lower back or their neck begins to close off and the holes get smaller and pinch the delicate nerves that go down through your knees on their way down to your feet. And so we'll find 30% of our patients will actually have stenosis that's causing their knee pain. 20% of people, as the first sign of sciatica, have intense knee pain without having back pain or leg pain. So just relax. This is what we do. And as we do your exam, we'll uncover these and we'll explain it all as we go. We'll take x-rays as is necessary. And if need be, we'll order an MRI. But we'll go over all of that information together so that you feel comfortable and understand thoroughly what it is that we plan on doing and what type of results and or risks we expect. The great news is, though, because we use such conservative methods, the risks are very, very minimal, and our staff performs everything in a sterile environment. You are numbed beforehand, and you're able to drive yourself home so that it's numb it locally so that you feel very little, if any, pain, mostly just a little bit of pressure. And the great news is usually after 72 hours, you're back up to full speed doing whatever it is you normally do. So I'll be with you shortly, and the key thing that we're looking for is, how much real estate is there? Is it a grade 1, 2, 3, or 4? And that will determine what we can and can't do. And it'll also determine what will work short-term, but more importantly, long-term for you, so you can get back to doing the things that you enjoy most without the limitations of pain or limited mobility.